Do tell me, do tell me if you guys can see the screen, right? Are
Yes,
you
we can
having any
see.
difficulty? Okay,
Yeah, we
so
can
let's
see.
start. So, as we all know that MRCS Part B is basically OSCE exam. So there are stations that we have to go through and pass the exam. So let's start from here. So basically, as a all we already know that there are almost 19 stations. 17 of those 19 stations are the exam station, and just one or two stations are the preparatory stations. The rest station where we are given some rest, and the other are all the interactive stations. And as we know it, that each station, in each station we get like 10 minutes. Uh, as you can see in the image in the picture, that the candidates are waiting outside the rooms, and you get 1 minute to read the instructions, and then 9 minutes to execute what is commanded. Then you enter into the room, and then you do whatever the commands are. We will further discover about all these things. Each station has 20 marks. Mm, Usually, the MRCS Part B exam is divided into two portions. One is the knowledge portion, and the other one is the skill station. So, the knowledge portion, in knowledge portion, there are stations regarding the anatomy, pathology, and critical care stations, and it has a total marks of 160. And in skill station, there are history taking, communication skills, there are examination, and then procedure. Four parts of that. So we will see how many stations are allocated to each one of them. So as you can see that there are, as I told you, knowledge and skill portion. In the knowledge portion, there are 8 stations that are allocated to anatomy got 3, and then critical care also has 3 and 2 stations of pathology. Similarly, in the skill portion, there are 9 stations, and there are stations of history, surgical skills, or procedures, physical examination, and communication stations. So this is how they have divided the MRCS Part B exam. Uh, as I already told you about the stations, 3 anatomy stations, 2 pathology stations, 3 surgical critical care stations. Similarly, there are 2 history taking stations, and then there are 5 stations, 3 physical examination stations, and 2 clinical skill stations. And there are two also the communication station, one each, one with the patient and relative, and the other one with the healthcare professional. So this is the division of all the stations, so it makes like 17 stations. So you have to go through the 17 stations and pass these stations. Well, they basically the both there will be two part of the exam, in the first part, and then there is a break, and then the second part. So you have to pass both these portions, the knowledge and the skills, separately. The passing is not in combined form. You have to pass the knowledge portion separately, and you have to pass the skill portion separately. That's how the marks are uh, made in the final result. So let's go through our today's session. That is what kind of and how the stations will come. So as you can see that this is one of the very typical anatomy station. That is how you will wait outside the room. There will be some instructions regarding the station inside the exam. So they will tell you something about that. In this station, we will be testing your anatomy knowledge. So after that, you will enter into the room. The bell will ring. You will enter into the room. There will be a chair and an examiner. So you will sit on the chair, and the examiner will hand you over this picture, or he will show you this picture, or some other pictures uh, together with this one, and he will tell you that uh, identify the structure number 27. So who wants to attempt this one? Is there anyone? Come on, guys. We want participation in this session, please. Come on, you have to attempt this. The maximum, what will happen? The maximum, you will not be able to answer this. That's not a bad thing. Come on, guys.
Is it cephalic vein?
The 27th.
Yeah.
We are talking about 27. Okay, okay. I will not tell
Oh,
you if it is right or wrong. I will just move toward the next one. Okay. So that's your final answer,
Is it
27th, right?
flexor pollicis longus?
The 27th,
Yes.
number 27.
it's the
Mm.
radial artery.
This is the number 27.
Yeah. So the 27 is
Radial artery.
Someone said something. What you said?
Radial artery.
Exactly, correct. So you get 1 mark for this for this one. And now can you tell me what is the 31 number?
That one is the median nerve.
31. This one, 31.
31.
Basically, in this picture, there are a lot of marking, but usually in the exam there will be just 2 or 3 markings, like 27, 31, 8, or 29. Not that much marking, just 3 or 4 marking. They will be specifically asking you what is the
Mm.
structure 27, what is the structure 31, what is the structure 29. You got me? So this is
Yeah.
how the stations will come. So now who will tell me what is the 31, the structure number 31? So
It's
27 was
Basilic
ulnar.
vein.
radial artery. The 27 was radial artery. So what can be 31? Anyone?
Basilic vein.
31. This is hand almost raised.
Mm.
Is it ulnar nerve?
No, 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 no. What?
Very good. You guys are doing good, but does it look like a nerve?
No, I think it's ulnar artery, maybe.
Very good. This is ulnar artery. Very good.
Yeah.
Very good guy. And what about 29? What about the structure 29?
Uh, is the superficial arc.
I can't
Which
see
one? Very
29.
good, very good, very good. But
Yeah.
you have to say it completely because they have the keys with them. So they have to mark the key. So they will ask you again that can you tell more about it? What superficial arc?
Is the superficial palmar arc with the greatest
Exactly.
contribution from the.
Exactly. That's excellent. That's perfect. So the next question will be, how is a superficial palmar arc made?
It is made up by the mostly by the ulnar artery, which comprises
Very good.
which is joined by a small portion of the radial artery.
Very good. So it is basically mainly formed by the superficial division of ulnar artery, the 30, the 31 of the radial artery, the 27 number. You got it? So 27 is radial artery, 31 is ulnar artery, and 29 is the superficial palmar arc. So this is basically the station is about the superficial palmar arc. You got it? There are a lot of numbering, but that is because we have this in the in our documentation. But usually they will just point toward 1, 2, or 3 things, not more than that. So this was one of the mock station of the anatomy. and they really like it. They like the extensors, they like the ligaments, they like the compartments, they like the nerves, they like they like these kind of anatomy stations a lot. So guys, very good guys. You did it very well. So let's move toward the next station. Let's see what is the next station. So the next one is also we have also got the another anatomy station, and this is the basically the abdominal anatomy. So well, there are a lot of structures, a lot of markings, but let me tell you a few things about the about this. That similarly, you will get the instructions outside the door, outside the room. There will be on the door. There will be instructions about the anatomy station that they are going to test your anatomy, and they may specify if it is abdominal or limbs or anything. Usually, they do specify it. When you will enter, you will get this picture, and then they will start asking you that what is the structure number two. Can anyone tell me?
Two is the celiac trunk.
Very good, exactly. So the now the next question will be, what are the branches of celiac trunk?
We have the splenic artery, uh,
Okay,
left.
one of that is splenic artery. Very good.
We have the left gastric artery and the common
Exactly, very
hepatic
good.
artery
What is the
and the
third one?
common
Okay,
hepatic
very
artery.
good, very good. So celiac trunk has three branches mainly. Well, the mnemonic is LHS. So L is the left gastric, H is the common hepatic, and S is the splenic artery. That right? Yeah.
Yes.
So 2 was celiac trunk. So what is 11 then? What is the number 11?
Left gastric artery.
Which one? Which gastric artery?
Left gastric artery.
Exactly, left gastric artery. So this is the first branch of the celiac trunk, left gastric artery. So what will be the number 3?
Common hepatic artery.
Common hepatic artery. Exactly. Very good. Very good. So as we know that there are further branches of the common hepatic artery as well as the splenic artery, right? So can anyone tell me that uh what is the number 7? 10 and 7. Any guesses, any idea?
Could be the uh, 7 could be gastro epiploic.
Gastro?
Epiploic.
Gastroduodenal.
Gastro.
Yeah, it is gastroduodenal, not gastropiploic. Because as you remember that gastropiploic are two left and right gastropiploic on the greater
Yes.
curvature side. So what will be the 10? Number 10? So basically this is the hepatic proper artery, okay?
Hepatic artery proper.
Yeah.
Yeah.
Yeah, so we have common hepatic artery and then there are branches of common hepatic. One branch is the right gastric. The second one is gastroduodenal artery. The third one is hepatic proper artery from where comes the left and right hepatic, and then there might be one or two other arteries. So can you tell me that what is the number 25?
25 is splenic.
Exactly, this is a splenic artery. So have we got any branches of the splenic artery? Are there any further branches?
Yes. There are the splenic supplies. It is pancreatic branches,
Uh-huh.
which which goes to the pancreas. It has branches
Okay.
which goes to the stomach as well.
Uh-huh.
The omental branches which goes to the stomach, and then on its termination, when it goes into the leonrenal ligament, it terminates.
Mhm.
It terminates by supplying the spleen before entering the leonrenal ligament.
And also the
Okay. Okay.
short
That's
gastric artery at the end part. It brings a short gastric to
The
okay.
the
left
from this.
gastroepiploid artery.
Yeah. So exactly. So mainly, one of the important thing in attempting these kind of exams is that you have to be very brief and very short, because the examiner will have a list of 10 or 12 questions. So the more you take time, the less you will mark all the questions. You got it? Like there are they have 10 or 12 questions. They will start asking you one by one. So they will give you time, whatever time you want. But that will cost you the questions. So you have to be very brief and you have to be accurate. You just answer the name of the branches. You don't have to explain anything more. You just tell them that splenic artery has the branch of celiac trunk has pancreatic branch, pancreatic artery, short gastric arteries, and left gastroepiploic arteries. You got it? So when you will answer this, they will move toward the next question. So then you will answer that, and they will mark the other question. So you try to complete all the questions, because if the questions will be left, read all the questions. Yes, once you are done with all the questions, that is how we were told, and that is how we did in our exams. In many stations, I answered all my questions, and there was some time, like a minute or less than a minute, and I would use to ask my examiner that is there any question that I can improve. So they would tell me that would you like to answer this again? So I would improve my answer. You got it? So that is how first of all you have to answer all the questions and correctly answer that. But if you get the time left, so then you can ask them again that if there is any answer that you want to improve, or is there any answer that you can improve. Then the examiners are usually very friendly. It is not the typical. I don't know if most of you guys must be aware with the exam structures of Pakistan, India, Bangladesh, these kind of. It's
Yeah,
very,
yeah.
very tense exams stations, the environment. But in MRCS Part B, you will get to know that they are very relaxed. They try to accommodate you. They make you feel very good. They will tell you that sit, relax, be relaxed. You can answer it. Yes, you can answer it. So they will be very, very comforting. So that is how a few tricks for the exam. So this was our another the second one, anatomy station. You guys did very well. So that means you guys are preparing good. So let's move toward the another station, third one. Okay, so we have got the image. So you have to identify the structures. First of all, can you tell me what are these structures?
Vertebrae,
Uh-huh. What kind of vertebrae?
cervical vertebrae,
Uh-huh. Okay. More specific?
atlas and axis.
Uh-huh. And what number is the axis and what number is the atlas?
Atlas is number one and axis is number two, I guess.
So we have got first cervical vertebrae and second cervical vertebrae. Can you tell me which images are of the first cervical vertebrae and which ones are the second cervical vertebrae?
Yeah, number A is for cervical vertebrae.
Uh-huh.
Then also number B.
Uh-huh.
Uh, yeah, these two are for cervical vertebrae, and number C Number D and number E are second cervical vertebrae.
Uh-huh. Okay, very good, very good. So can you tell me what is the structure 2 in the image A and B?
Yeah, can you repeat the question, please?
What can you identify the structures with the marking 2, number 2 in A and
Uh,
B? In A and B.
it's posterior arch, maybe.
Mm-hmm. Mm-hmm. Okay. Anyone else want to attempt this? And what is the structure 7, number 7 in image A and B?
I guess it's anterior arch.
Mm-hmm. And what is the structure 5 in image A? Nothing to worry about. We are just trying a mock. So this is just a practice session. As they say that if you sweat a lot in the practice, you will bleed less in the battle. You got it? So basically the structures 2 in the image A and B, basically they are the facet for dens of the axis. A and B are atlas. So as we know that axis has a structure called dens or odontoid peg. So these are the facet. The two is facet for the odontoid peg. While the structure 7 is posterior tubercle. Structure 7 is posterior tubercle. Similarly, the structure 6 is posterior arc, whereas the 5 is lateral mass with superior articular facet. Similarly, the structure 4 is the lateral mass with inferior articular facet. So these are regarding the atlas, first cervical vertebra. So similarly in structure C, D, and E, there is a structure 4. What is that structure? Structure 4, number
It's
4.
odontoid process.
Exactly, exactly. So, and what is the structure 2 in C and E?
Bifid spinous process.
Sorry?
Bifid spinous process.
Exactly, exactly. Very good, very good. And what is the structure 3 in image D?
Uh, Body of the second cervical vertebrae.
Mhm. Exactly. And does the atlas or first cervical vertebrae has a body?
No, it doesn't have. It only have the arch.
Exactly, exactly. Very good. So the atlas is the only vertebrae that has no body. And what is the structure? What is the structure 11 in the image C and E?
Vertebral foramina.
Exactly. It is vertebral foramen. So very good, buddy. So this is how the images usually come, but you have to practice them a lot. And believe me, you already have the data, you already have the documents, is mainly the performance that counts in the exam, that how well you perform in the exam. God forbidden, if, for example, anatomy is your second or third station, but before the anatomy, one station from pathology or any station, if you could not perform well in that station, then you have to control your nerves and you have to go to the next station and perform well. So you got it, because there is huge adrenaline rush in the exam, because of all the pressure, because of your preparation, the time you have spent, the money you have spent, the hopes you have. All these combined uh, will cause a lot of adrenaline rush. So, in that adrenaline rush, performing well is what is required, and that comes from the practice. The more you practice, the more you practice, the more you will perform well in your exam. So, let's move toward another one. So, let's see what station we have got in the next one.
Well,
Oh, so
will
that is
there be any live specimens?
no. Usually, usually there are images. Usually they give it in the form of diagram images or images cadaveric images. Or in some cases, we have heard in Malaysia, in some of my seniors once told me that they were given the dummy kind of the dummies were there and they would point with a stick toward the shoulder or toward the neck or toward another thing. And in one station recently, someone told me that there was a patient, and patient was lying down on a couch, and that was the regional anatomy. So they would ask them about the regional anatomy, that what are the markings of gallbladder, what are the marking of other thing, anterior superior iliac spine, or other thing, another thing. So that is, so basically you cannot say for sure how the things will be, but you have to prepare yourself very well for all these things. Anything else? Should we move forward?
Yeah, thank you.
But do not worry about this. The only thing is, important thing is that you practice yourself very well and you're prepared for all these things. So, this is the pathology session. So you will enter, you will outside the room, there will be something like that. They will give you a scenario that a young lady with endometriosis, concerned that her father died of a cancer or a colon cancer at an early stage. She had a colonoscopy just now, and these are the images of the colonoscopy. So they will be asking you a lot of questions. Like they will be asking you first of all that, can you identify a picture? What is this picture? So you will say that this is a picture from, as we already know, a colonoscopy. So what is there? What are there in the colonoscopy image? So what can you tell me something about this?
Yeah, there's a lot of polyps,
Uh-huh.
which can indicate familial adenomatous polyposis coli.
Oh, okay. Mhm. So what is the next question will be, can you define the FAP or familial adenomatous polyposis? As I already told you, they will have uh, the number of questions already written. They will have the keys, so they will be asking you one by one questions related to all these things. And one of the important thing is, guys, if you do not know the answer or if you cannot remember it immediately, you can ask them that, can I skip the question and answer the question later? They will tell you yes or no. Most of the time in my exam I did that, and they once or apart from once or twice they told me that yes, I can answer that later, and in the end I told them again that I wanted to answer that question now. You got it? So just be very relaxed in your exam. If immediately you cannot remember an answer, tell them that I will answer this question later. Can you move toward the next question? So, for example, if I ask you that, please define FAP, or can you define familial adenomatous polyposis, and you cannot answer immediately that. So you can tell me that, uh, can you move toward the another question, I will answer that later. So, anyone want to define the FAP?
It is an autosomal dominant condition
Uh-huh.
characterized
Okay.
by lots of ABC gene in the ABC gene in the short arm of the chromosome 5, leading to
Uh-huh.
undifferentiated يعني multiple divisions
Okay.
of the cells of the colon, leading to multiple polyps eventually.
Uh-huh. Okay. So as you already told me, there are multiple polyps in this image. So can you classify polyps? How many polyps? What types of polyps do you know?
The polyps are divided into two. We can say they are cancerous or non-cancerous. The
Uh-huh.
cancerous
Very good.
include tubulovillus and tubulovillus, and
Mm-hmm.
the non-cancerous include pseudopolyps, hamartomatous polyps. Uh, I don't recognize the others.
Mm-hmm. What else?
Metaplastic as well.
Mm-hmm. Okay. So can you tell me about Gardner syndrome?
The Gardner syndrome will have some osteomas, maybe.
Will have
Osteoma.
okay, osteoma. Okay. Like you want to say that apart from the polyps, it
Yeah,
will has
yeah,
it will
there will be
have
some, yeah, there will be some osteomas.
yeah, mandibular osteomal. What else?
Mhm. And abnormal rectal bleeding will be here as well.
Hmm. Yeah, desmoid tumors, sebaceous cysts, osteomas, and polyps in many and apart from other things. So these are the part of the Gardner syndrome. So and can you tell me that what the malignant potential of the adenomas depends upon what factors? This is one of the type
Depends
of the
on the
question.
number. On the
Yeah.
number. The more polyps, the more malignant it will be.
Uh-huh. And what else?
And also the size. If the polyps
Size.
are, yeah,
Hmm.
And type.
What else? Yeah, exactly. As we discussed the types. So type, diameter, or size. If it is less than 1 centimeter, then the chances are the 5% risk. But if the size is 2 centimeter, then the chances raises to 20%. And similarly, the degree of dysplasia in the adenomas. So these are three factors: types, size, and degree of dysplasia. So if you again read the scenario, so basically the scenario is a young lady with endometriosis. So they will not just test you for the polyps, but they will also ask you a few questions about the endometriosis. So what is endometriosis, or how can you define endometriosis?
ليه الناس ما أعرف أظنهم باكستان ولا شنو أعرفوا.
Is the presence of ectopic endometrial tissue outside of the uterus, mainly due to hormonal
Exactly.
change.
Exactly. Very good. Very good. So these are the kind of questions that they usually will ask you about these, and usually the questions that we have got in the Salah or in Turkey or in other kind of notes, basically 90% of the questions will come like the same things. They might add one or two. They might add one or two extra stations some kind of new station, but most of the 90% of the exams are from the same documents, from the same stations, from the same topics. They will not change whole of it. They will just change one question or two question, nothing else from that. So in this case of the familial adenomatous polyposis, as we have got it, so what is the management plan? What do we do in such a cases of FAP? So basically, by the age of 25, usually the surgeons perform prophylactic near total colectomy for such a cases. And similarly, there is another question regarding this, that if the patient has a 2-year-old child, what will be the management plan? So basically, till the age of 12, until unless the child has reached the age of 12, by that age, we usually start screening for the FAP by colonoscopy. By the age of 12, we start screening for colonoscopy. Similarly, one of the important question in such a scenario they usually ask is that lifestyle modification to reduce the risk of colon cancer. Can someone tell me what are the lifestyle modification?
Stop alcohol and smoking consumption, and
Yeah, yeah.
taking low fat diet.
Mm-hmm. Okay, good. And similarly, all the healthy habits like a fiber-rich diet, stop smoking, reduce fat intake, limit alcohol, all these things are all the healthy lifestyle things. But usually they like to ask questions like these, and we have got two stations of pathology, and we already know the topics. So with very good practice you can perform 100% in these kind of stations. Similarly, in anatomy stations, if you have practiced very well, you can get 100% marks, because they will ask you what is structure A, what is structure B, what is structure C. And if you know it very well, you just have to mention the answer. You have just answer the thing. You don't have to explain anything. So you can get in the three stations of anatomy, you can easily get 100% of the marks. Similarly, in pathology stations, you can get 100% of the marks if you know the answers very, very well. There are few questions that are very tricky questions and very hard to remember question. Like they usually ask about the genes, the APC genes, the mechanism of few things, and those are the things that in such a state of mind, you usually miss few things. So that's why you can have a 1 or 2 mark lesson, but in anatomy you can answer 100%. So let's move toward another station. So this is the next one. Next station is our the critical case scenarios. So we have got a middle-aged man, having osteoarthritis, and for that he must be using the NSAIDs, non-steroidal anti-inflammatory drugs. And now he came with severe abdominal pain, vomiting, and rigid abdomen. And you have ordered a chest X-ray with diaphragm, and this is the chest X-ray with the diaphragm. So, so let's start with the question. So what do you think the most likely diagnosis is?
Perforated gastric ulcer.
Huh? I'm talking about
Perfo-
diagnosis.
uh, Maybe perforated gastric ulcer.
Okay, yeah, okay, it can be. What do you see in the chest X-ray?
There's A under the diaphragm on the right side.
Yeah,
Okay.
there's the free air level it's very obvious at the right side, but at the left side, because of the fundus, sometimes it was mislead us, but as we can see in both sides, there are free air under the diaphragm.
Okay. Okay. That's well explained. We've got it. So what could have caused the perforations? What are the risk factors overall and in this patient?
Uh, use of NSAIDs,
Very well.
smoking,
Smoking.
sm
What else?
maybe alcohol, previous
Maybe
previous history, maybe previous history
previous history of what?
of maybe peptic or gastric ulcers,
Okay, that's very good. Very well. Anything else?
malignancy,
One or two?
malignancy maybe.
Okay. Yeah. Very well. So we have got NSAIDs. We have got previous history of peptic ulcers. We have got smoking. We have got alcohol. We have got malignancy, H. pylori, Helicobacter pylori, infection, and similarly the steroid use. Those are a few of the risk factors of perforation. How can NSAIDs cause peptic ulcer?
Uh, they inhibit the prostaglandins.
Okay. One of the mechanism that they causes the perforation. What else?
Uh, Inhibition of the maybe blood flow of the mucosa.
Exactly. Reduction of the gastric uh, mucosal blood flow. Very good. Similarly, they causes the topical irritant effect. They have the topical irritant effect on the epithelium. Likewise, they impair the barrier properties of the mucosa. They suppresses the gastric prostaglandin synthesis, and they also interfere with the repair of superficial injuries. The injuries that's already there, uh, they usually interfere with their repair. So these are the ways that the NSAIDs uh, causes peptic ulcer formation. So in this case that we have diagnosed as air under diaphragm and perforated peptic or duodenal ulcer, what will be the management options? What is the management plan in this case?
So in this case, you manage according to the critically ill patient, and
Uh-huh.
you 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 keep the patient new per oral.
Uh-huh.
Then you do all the things like inserting catheters, and if there is any need, you can insert a nasogastric tube on the patient.
Uh-huh.
Uh, then our mainstay management is mostly surgical.
Mhm. Okay.
So
What kind of surgery? What kind of surgery or what will you perform in the surgery?
it's modified Graham repair with an omental page.
Exactly.
If it's a duodenal, if it's gastric, that's when you are allowed maybe to take a biopsy so during the operation.
Exactly. Exactly. Very good. Very well. Very well. Very well explained that. Answered that. And what is important medication post-operatively that you will give to the patient?
It's PPIs.
Hmm. Exactly. So the next question they might ask you is that what is the mechanism of action of PPI?
Uh, they inhibit the H plus potassium pump on on the apical surfaces of the cells of the gastric mucosa, so thereby inhibiting the release of H plus, which will combine with chloride to form HCl.
So and they bind with the uh pumps irreversibly or reversibly?
Uh,
It's
I couldn't
reversible.
hear you there.
So they binds irreversibly with the pump.
All right.
Okay. And as you said that they will cause mm, the inhibition of HCl formation. So what are the actions of hydrogen chloride?
Uh, it stimulates. It acts as a protect protection barrier of the mucosa of the stomach as well.
Mm-hmm.
It stimulates absorption of maybe things like iron. It aids in the absorption of things like iron. It stimulates a release of enzymes such as CCK and
Mm-hmm.
secretin.
Mm-hmm. Cholecystokinin secretin,
Also,
exactly. And what else? What's the main one action? The important action that it activates the pepsinogen to pepsin.
Pepsinogen, yes. Yes.
And apart from that, it stimulates the CCK secretin. It promotes absorption of calcium and iron and all these things. Very good, doctor. Very good. You have attempted it very well. So, apart from that, regarding this diagnosis and this kind of surgery, they might ask you regarding the categories of different type of surgeries, like priority of the surgeries or the operations according to the classification. How do you classify the surgical cases into the immediate, urgent, expedited, and elective? That is one of the important thing. Do do memorize that.
All right.
What are the immediate
Uh,
surgeries? What are the urgent surgeries? What are the elective surgeries? So do you remember? Can you give me example of an immediate surgery?
yes. On immediate, it's usually bowel saving or limb saving. So we might have abdominal aortic aneurysm repair.
Rep
Uh,
yeah, repair. No, but elective
uh,
repair or what kind of repair? We are talking about immediate surgeries.
ra- immediate, we have repair of ruptured aortic aneurysm.
Ruptured. Yeah, exactly. Very good.
Then on agent, we may have uh, uh, maybe perforated viscous. We are doing surgery on perforated viscous, or maybe ac-
Mm.
acute coronary syndrome as well.
Okay.
It falls on
And what?
agent. Then
Okay.
expedited, we may have tendon tendon repair, or maybe excision of a tumor with a potential to
Mhm.
bleed.
Okay.
Then on elective, we may have maybe laparoscopic cholecystectomy.
Yeah, exactly. The elective are that we can easily we can plan them in a relaxed environment. So these are, but these the thing is that you have to memorize these things. This kind of the tables, this kind of the categories. So these are also one of the important in these kind of stations. So very good, doctor. You attempted it very well. So let's move toward the other stations. So these were our knowledge stations. All of these were the knowledge stations. Now we are moving toward our skill stations. As we discussed that there are nine stations, two history stations, two surgical procedure stations, three physical examination stations, and two communication stations. So basically, there are two from the history and two from the communication. So both of them are almost the communication type, that you have to talk, that you have to get the information, you have to give the information. So these are the four stations. And the practice, verbal practice, the tone practice, everything is must in these four stations. So you have to practice them very well, because we are not native. The English is not our first language. So we have to practice them very well, in very good manner. As you all must know, that in the history and in the communication station, there are two examiners. One examiner is a doctor, that will see that how good you take the symptom history, how well you move toward the diagnosis, how you take the history of differential diagnosis. But the other examiner, they will they will mark you, they will test you based on your tone, based on the wordings that you are using, based on how empathetic you are being to the patient. So there will be two examiners. And all these especially these four stations, you need to practice a lot, repeat them a lot, practice with your friend, practice with anyone that you can get easily, and do practice with them the histories again and again, do practice with them the communication. These are very important things. And in the surgical procedure and physical examination, you can also see the, if you are working in a hospital, it's very well, you can time yourself with the examination, you can time yourself with the procedures. And if not, then at least you can see the videos of the examination and the procedures again and again, and mock that. So this is why this is very important to practice. So let's see what we have got in the next sessions. So in the history taking, outside the room, there will be a scenario like you are the surgical SHO in the OPD clinic. A 23-year-old female present with right lower abdominal pain for the last 2 days. Take a focused history from the patient. At the end, explain your differential diagnosis and plan to the examiner. So basically, you will get 1 minute outside the room in reading the scenario, and after the reading scenario, in this 1 minute you will plan your move, how you, what you have to ask and how you have to ask. So in this scenario, you have got the idea that the patient is with abdominal pain, so you have to take the history for abdominal pain, but you also have to move toward a diagnosis. You have to make a diagnosis that what it can be. If she is 23-year-old female with a right lower abdominal pain, so it can be many things. So you will have to move toward that direction, taking history, and you have got 9 minutes inside the room. So as you will enter into the room, the examiner will just ask you that tell me your number. So you will tell them your examiner number, and after that he will tell you that you are ready to start. There will be a patient will be sitting on a chair, there will be another chair, you will go and sit on that chair, and after that you will start taking history. You have got just 5 or 6 minutes to take the history, because after that there will be 3 minutes. In 3 minutes you will have to present the history and tell your differential diagnosis and answer the examiner. If you will not be able to take the history in 5 or 6 minutes, you won't be able to answer the questions of the examiners. So that will be a loss for the stations, because they will just mark that your questions were not answered. You got it? So that is how, why the practice and timely practice is very important. You have to time yourself. You have to take history quickly in these days, and being empathetic, being very soft, being very gentle. You have to be very careful with the patient. I will tell you few of the other scenarios. Similarly, there can be a scenario that you are surgical SHO on call. You are asked to see a patient in emergency, accident and emergency, who has abdominal pain. Again, a history of abdominal pain. So you remember the histories, right? From the Bazir or from the other documents. There are like 3 or 4 histories. four histories from abdominal pain. Status, the other one is acute pancreatitis, the other one is IBD, the one is IBS. Similarly, there are few histories and examinations of the appendicitis. There are few there is one examination of acute cholecystitis. So you have to keep that in mind. Similarly, the third scenario is you are seeing a patient with pre-admission clinic. They have been experiencing occasional chest pain. Please take history. Now you have to be very careful with the chest pain if it is due to the anxiety or if it is some cardiac issue. So you have to take all that history. Similarly, the fourth scenario is Mr. Jones has come to see you, an orthopedic SHO, in clinic as he has been getting back pain. Please take a history and then present your finding to the examiner. So this is a history of back pain, a functional back pain, or there is some column vertebral column issues or what it can be. Take all these history. So you have to be very careful with in such a cases because in my exam I remember I had a patient with a knee pain and the patient was the patient was telling me again and again. In the start, I asked him that what was the reason that he came. So he told me that he is having a knee pain. Then again, he told me that he's having knee pain. So I, I asked the patient that, do you want me to bring you some painkiller, or can we advance with our history taking? So then he told me that no, that's okay, we can continue with the history. So basically the patient there will those are not patients, those are actors. They already know what they have to say and what they have to do. So they will be teasing you, they will be judging you, they will be testing you in different ways. Similarly, in one of the station of my exam in clinical examination, there was a young boy with ankle injury. And as I started to touch him, he started shouting that I have pain, I have pain, I have severe pain. So I told my examiner that I will not be able to examine my patient because my patient is in severe pain and I want to give my patient some painkillers. So I can ask my staff to bring some painkiller for the patient or injectable form. So after that, my examiner told me that okay, that's okay, you are done. Now come for the viva questions. Then he started asking me questions that what investigation I will perform, what will I do, how will I do, all these questions. So they are basically testing you from different angles. Not just They are not just testing your knowledge, they are testing your skills. So this is how you will have to be very careful with the history taking. So someday, inshallah, we will try to do just the skill portion because it will take some time for mm, some of you to perform this. Similarly, as I told you, in communication, we have two stations. One station is a communication with the patient or attendant. The attendant might be the wife, the attendant might be a parent or someone else, and similarly communication with the patient. So these are the scenarios, like an anxious patient for daughter having perforated appendix, an angry patient waiting for the arthroscopy, counseling a patient before stopping warfarin. All of these are all of these are very very excellent scenarios. Basically, there will be an angry patient and you will have to deal with them. So you will have to be very careful with your nerves. You have to be very soft with them. You have to be very apologetic with them. If you remember this scenario of the arthroscopy, uh, the actor or the patient will be forcing you towards certain things, but you will be apologizing. I'm really sorry. I'm really sorry. In first, the patient will tell you that call your consultant, and you will tell them that I'm really sorry, but I cannot call my consultant because he is in the operation room, operation theater, OT, OR room. Then he will tell you that call another consultant. Then you will tell you that I'm really sorry, I cannot do that. That will take some time. Then the patient will tell you that Okay, give me another date of for the orthoscopy right now. You will again tell them softly that I'm really sorry. I'm really sorry, but I cannot do that. I will have to discuss that with my consultant, and I promise as soon as I discuss that with my consultant, I will call you and I will tell you the date of your next appointment. Then again, he will tell you that promise me that the next time uh, it won't be delayed. So you will again apologize. You will again tell them that I'm really sorry, sir or madam or miss or whatever the name is. That I'm really sorry, but I cannot promise this because our hospital is a big hospital, a tertiary care hospital. All the time we are having emergencies, and anytime any emergency can come. And a life or limb saving energy emergency is always prioritized over the other cases. So I cannot do that. So, so this is a very beautiful case, very good scenario of the communication with an angry patient. Similarly, there might be you will have to take consent for colonoscopy, so, or you might have to break a bad news of some malignancy to a patient. Similarly, you might have to explain a diagnosis to the patient. So these are different kind of scenarios that you have to give time and practice all these scenarios. And the other station, as I already told you, that there will be another station of the communication with the consultant. So you will have to communicate with your colleague, consultant, or doctor's consultant, orthopedic, or anyone, and tell them some things. Guys, are you with me, or I'm just talking? Hello, guys, are you there?
Yes.
How difficult you guys are dealing with the communication stations? Have you already practiced that? Have you already practiced the communication stations?
Yes.
Uh-huh. So are you doing good in that? Do you need any tips?
Yeah, we might need some tips.
So these stations are very good stations, but you have to do very well in these kind of stations by practicing them. In the phone call with the consultant, so there will be a room. You will enter into the room. There will be a table and there will be a file, and there will be a white paper and a pen or a pencil. So you will have to quickly take notes and read the file of the patient. There will be like this patient came on that date and he was having this and this. Then we did investigations and everything. And then there will be another page. They will say that on this day, on other day, on the next day, this happened. Then on the next day, this happened. And now today the patient has this. So you will have to make some quick notes because after the bell rings, you will have to enter another room. And in another room, there will be a phone set. You will pick the phone set, and there will be your consultant or another doctor, and you will have to communicate with him. You will have to tell him. For example, if there is a patient with a CBD injury or bile leakage after laparoscopic cholecystectomy, so you will have to pick up the phone and you will have to inform them that who are you and with whom you want to talk. And once you confirm that the hepatobiliary surgeon is on the call, then you will start, he will ask you to summarize the case. Now you will have to say that my patient John, he had a laparoscopic cholecystectomy 4 days ago, and the surgery was done very well. But now the patient is having bile leakage in the drain. You will explain that abdomen is soft. His labs are this TLC is this, bilirubin is this. You haven't performed the ultrasound yet, but you will order the ultrasound, and then you will he will he will start asking you few questions regarding the scenario. So you will have to answer those questions. You got it? So this is how these stations will, but there are very few stations like these 7 or 8 stations. So you can practice these stations multiple times, and believe me, same these stations will come into the examination, nothing else. No extra stations will come into examinations. So you have to practice, guys. Let's move toward another one. Yeah, procedures. Procedures are very important. There are few videos that you can see again and again, but again, as I told you that there is adrenaline rush. So you have to make some way and practice these in your hospital, in your clinic, in your home, or wherever you want. But do practice them, because once you will practice, you will make a routine of them. You will know what I have to do. Similarly, there are few topics like male catheterization. This is a kind of a difficult one, but apart from that, there is like making a surgical OT list. Then there is incision and drainage. Then there is closing a wound. Similarly, debridement. So these are all the procedures that you have to do. And believe me, this makes in the exam, if you haven't performed them, then you will get a lot of difficulty. So try to perform them. Try to time yourself and perform them. Uh, the important thing in these is I can just tell you how the scenarios are. That outside the room there will be a written scenario. So when you will enter into the room, for example, if the scenario is that male catheterization, you have to do pass a Foley catheter. Then when you will enter into the room, there will be a staff nurse, there will be examiner, there will be a set of instruments, and there will be a dummy. And now they will ask you that whenever you are ready, now you will have to enter. You will have to tell them that you will, if there is a real patient, then you will have to counsel the patient. You will have to introduce yourself. You have to confirm the patient's his name, and after that you will have to tell him what you are going to do in a layman wordings. And you will ask few questions like allergies. You will have to ask about the allergies of the patient. You will have to ask about the previous history, if previously he has ever been uh, catheterized. And similarly, you will tell him that now you will start. Then after that, you will move toward the staff nurse and you will ask her regarding the instrument. She will ask you what is that you want. You will ask her that I want uh, gloves, surgical gloves. I want the syringe. I want the sterile water. I want the Foley's catheter. I want the lubricant. I want sterile drapes. I want cotton. I want pyodine or other sterilizing solution. So after that, you will move towards the patient and you will perform all the steps within the time. And once you are done, then you will have to dispose of all these things and make sure that your patient is comfortable. And in the end, you will make sure that you document the thing, or at least you tell your examiner that I will document in every procedure. You will have to take care of these things, the documentation. So these are all of these are steps in MRCS exam. One of the good thing is this one, that you until that there is not a single blunder that you make and you will fail the exam. All these steps matter. The examiner will mark you over all these steps. That has the candidate introduced himself, has the candidate confirmed the patient identity, has the examiner asked about the allergy, has the candidate performed the procedures well, has the candidate answered the question. So all these are markings. They will mark everything, and in the end they will make your total marks, and either you have passed it or you could not pass that. So all these steps matter, not just one thing, not just that you have passed the Follies. This doesn't matter. All the previous steps matter. So I hope you got what I wanted to say. We will try to uh, do some specific a specific session on the skills, because it is time taking. So I'll have to explain each and every one of the procedures. Do you have any question regarding the procedures? Do you find any specific procedure like difficult, guys? Guys. Right. So I have got a question from Tinashe. Tinashe have asked that I have a question regarding ICE. So do we have to do it during the history taking? Yes, it is very important. It is very important that you ask your patient in the in the history in the end, almost in the last part of the history, you ask them these things, that what the patient think is causing the issue, or what he is expecting from you. So these are one of the important thing, but you have to practice these. And yes, you have to ask them these things in the history, in every history, almost every history, you have to ask them. There are few histories like depression and some other thing, but apart from that, in other history, you have to ask them that what do they think is causing the issue, and what are uh, they most bothered about, and what are they expecting from us, from the doctor, or from you, that what are their expectation from this. So this was the procedure skills part. As I told you that you will have to introduce yourself, you have to confirm the patient's identity, then you explain the procedure in layman terms, then you gain a verbal consent that is that all right, can we proceed? Are you okay with that? And after that, you, if it will depend upon the procedure, that what kind of procedure you want to do. You prepare your equipment, you perform your procedure, you dispose of, if the sharps, then you dispose them in the sharp bin, and if other thing, then you dispose them accordingly. And in the end, it is always better that you yourself give instructions to the patient. You do not wait for the patient to ask you. It will make a good impression. And in the end, as I told you, that you will have to uh, at least tell the examiner that you will document the procedure skill. This is one of the, so in the clinical examination, as I told you, there are a lot of examination topics, orthopedic examinations like the shoulder, like the hand, the knee, the hip, the spine, the ankle, and apart from that, some general surgery examinations like thyroid, parotid, submandibular gland, abdomen, in abdomen acute cholecystitis, in abdomen acute appendicitis, these kind of examinations. Apart from that, there is breast examination, and there is the varicose vein, the lower limb vascular examination, similarly diabetic foot examination, all these examination. And you have to, again, as I told you, that you have to practice them very well, because you will enter into the room, there will be an actor sitting or laying down, and they will ask you that start whatever you want to do. Now, if you have already memorized the step, if you have performed the steps, then there in examination, it will be extremely easy for you to perform all these. So tell me, how are you guys doing the clinical examination practice? Have you guys already been doing it? Who will tell me? Tenashe, Tenashe, are you doing the practice for examinations? Guys, are you guys there?
Yeah, we do amongst our friends.
Uh-huh. So what examination do you find the most difficult?
We have things such as the use of fundoscopy. Some who
Uh-huh.
might not have copy, maybe
Uh-huh.
varicose, or we might not
Uh-huh.
find like exactly varicose, so just be doing on normal
Yeah,
people.
yeah, yeah. Okay, okay. So there are look, among these topics, there are few high yield topics. Like you will find them in in most of the stations. Like thyroid, they like the thyroid very well. You will find it a lot. So you have to practice thyroid a lot. You have to practice the ankle a lot. You have to practice the submandibular. In my exam, there was The stations was one of the station was the ankle examination, and the other station was the submandibular gland examination. So they like these kind of things. So you have to practice all of them and practice them again and again. So in this case scenario, the scenario is acute cholecystitis. So usually this is an ultrasound with the we can appreciate the stone here, but the walls of the gallbladder are not thickened. The sonogram only shows gallstone within the gallbladder, but no evidence of cholecystitis. So in this kind of scenario, usually they will ask you to perform a abdominal examination. So you will introduce yourself, you will gain the consent, you will make sure identity of the patient. Then after that, after the gaining consent, you will ask them to expose. And if there is a if it's a female patient, you can ask for a chaperone. And once exposure is done, you will start with the inspection, and after the inspection you will move toward the palpation, then percussion, and then auscultation. And once you are done, then you will ask for the file or ask for the investigations of the patients, if any done. And if not done, then you will you will summarize your case to your examiner, and then examiner will start asking you. He will ask you what investigation you will perform. You will say that ultrasound. I would go for ultrasound. Then he might ask you that what are the sonographic signs of acute cholecystitis. So you can answer them that the gallbladder wall will be thickened, there will be pericholecystic fluid, and there might be the dilatation of intra and extrahepatic if the stone is outside. Otherwise, you will see the stone in the gallbladder. So these are few of the questions that they might ask you. As I told you that in the steps of for the examination, you will wash your hand, introduce yourself, confirm patient's name, and explain the procedure, and gain the consent. And after that, you will expose the patient and perform the examination. And in the end, you will reposition the patient, and you will thank the patient. And don't forget to ask about existing pain before palpation. Yeah, that is one of the important things. So the key points for all these stations were that each station has 20 marks, last for 10 minutes. You will have 1 minute to read the stem, then 6 minutes to take history from the patient. The patient is always an actor. Two examiners will be there in the history station and communication station, as I told you before. So guys, this was all about the OSCE stations. I hope it will help you guys. I hope I was able to explain them in a very well manner. And I hope you have gotten the idea of how the exam is, how the stations are. So what we offer, what we can offer you is that we offer you a comprehensive OSCE mock series. We offer you an examiner-led feedback sessions. The sessions after each session you will have a feedback and individual performance analysis. We offer you high yield revision materials, as I told you about the high yield things. Similarly, we offer you live interactive sessions and some peer group practice support and access to recorded session that has already been recorded. And we will also try to train you for time management strategies. And similarly, we can offer you mentorship and guidance. Those are the things that we will help you guys, and these are the important things, because most of us are doing jobs, have families. We don't have that much time, so we have to balance all the things, and in such cases we need someone who can provide us with all these things, with the support, with our questions, with our queries, with mentorship, with guidance. So these are all that we will be offering you guys for the MRCS Part B preparation. So we have planned some sessions, and there are some 3 sessions that we will be doing for these OSCE stations, and each session will have some focused areas like clinical skill examination, skills, procedures, and we will try to cover as much stations per session possible. Similarly, like in session one, we will try to focus on the history taking, the examination, and the anatomy and these things. In session two, we will be planning to focus on uh, the other thing, the communication, the history station, the examination station. Similarly, in third session, we will again try to do some of the anatomy images, similarly some of the pathology stations, and similarly some critical care and procedure skills. So we will be doing all these sessions for you guys so that you can prepare very well for the exam. You guys can tell us about your plans. When are you planning for the exam? You can ask us questions. We will try to answer you as much and as soon as possible. So don't worry about that. I hope following our you guys are following our WhatsApp group and other groups. Uh, if you are not following, so I will request you guys to follow our groups and ask us questions, ask us whatever you want to ask, and uh, we hope that you will get our sessions. So what are the benefits of these the OSCE series is that as as I have tried, we will try to simulate a real scenario, what happened in the exams to you. It will identify your weak areas, and we will try to improve the clinical reasoning. We will boost your communication skill, and if required, we can offer you personalized feedback also. So, guys, this is all about today. So, you can contact us on this number, and you can follow our WhatsApp and other groups also. If there is any other questions or you want to ask any query, so you can ask. Guys, first of all, was it helpful or not?
It was very helpful. We managed to note down a few things, one or two things to try to improve on our preparation for the exam. Thank you so much.
Thank you, buddy. Thank you, Tinashe. So, guys, any question? If you have any question, any doubt, or anything to ask about, you can ask it now, or you can ask in our WhatsApp group and other on the phone number. You can ask them also. We are always available for you guys to answer your queries. So I will I will get back to Sarah. Sarah, what's the plan now?
Sir, they can contact. Hello, sir. Hello, all.
Yeah, yeah.
Sir, they can contact us on WhatsApp to register in OSCE mock series, and we will provide them the schedule.
Yeah, guys. So follow us on the WhatsApp, and Sarah will be in touch with you guys to give you all the details of the schedules. So see you in the next session, hopefully. Okay, guys, do give us feedback about the session.
Okay, thank you.
Okay, thank you. Thank you, Sarah.